Welcome back to PedsCrit. I'm Zach Hodges, a pediatric intensivist at the University of Texas Southwestern in Dallas.
And I'm Alice Shanklin, a pediatric intensivist at Cohen Children's Medical Center in New York.
And we're excited to be sitting down with pediatric intensivist Dr. Ryan Coleman to discuss hemodynamic support in high-risk PE. Dr. Coleman, please introduce yourself. Tell us who you are and what you do.
Sure. So thank you guys for the invite and opportunity to be involved. So my name is Ryan Coleman. I'm a pediatric intensivist and the director of the Pulmonary Hypertension program at Texas Children's Hospital in Houston, affiliated with Baylor College of Medicine. I'm an associate professor here. I spend the majority of my time these days taking care of kids with pulmonary vascular disease, but I'm an intensivist at heart. All of my training was in peds critical care and then some extra training in ECMO and PH. And so I will forever be an intensivist like you guys as well, even though I don't get to do quite as much critical care these days. And so that's kind of my role down here at TCH.
Oh, wow. Well, I know that TCH is the capital of the subspecialty within the subspecialty. How did you get interested in PH, or how did you pick that route?
So when I started fellowship, actually when I started residency, I was dead set I was going to be a peds cardiac intensivist. I really liked complex cardiac physiology. I thought at one point in my life I was going to be a pediatric heart surgeon, and even took a year off in medical school to do research because I really couldn't decide what I wanted to be when I grew up. But then ultimately, after spending a lot of time with surgeons, decided that was not the life for me. I will leave it there. And so then went into a residency and fellowship to do cardiac intensive care, and really ended up liking the PICU way more than I anticipated, and really got tired of arguing with surgeons about things like creatinine and diuretics. And so had kind of one of those mid-fellowship meltdowns where you're like, oh my God, what am I going to be? At the time, we had this run of really sick teenagers with PH at the time. And at TCH, we're a little bit different than most places in that pulmonary hypertension goes to the PICU, not the cardiac ICU. And so I was spending a ton of time with all these super sick teenagers who wouldn't get better. And so then it was one of those, do you run away from the fire or run towards the fire? And I was like, all right, this is complex. They're dying. I need to figure this out. And if I do this, it means I don't have to deal with cardiac surgeons all the time. So I got my complex cardiac physiology without the surgeon. So to me, that was a win. But here, there had never been an intensivist that did PH before. It had always been run by pulmonologists at TCH. So then I had to go ask my chief at the time if she'd be willing to let me consider this as a path. And she was like, sure, why not? Go for it. And so that's kind of a roundabout way of how I ended up in the PH world. And it's been great. I had to kind of go searching for mentors a little bit because there's not a lot of intensivists that do pulmonary hypertension. And so kind of create my own network a little bit just to find the right folks to help me figure out how to make this a viable career. But it's been wonderful. And like I said, I used to hate these patients because they were so scary, right? We all know the jokes about kids with PH, they have a bowel movement and die, and so I was like, well, either I learned to do it or I'm forever scared. And so decided to take it on. And it's been a great decision.
Well, that's a beautiful story. And I'm sure really resonates with the scenario of, I love the CV physiology. Am I ready to commit to the CICU forever? Or will be relatable to a lot of PICU fellows. So I appreciate it.
Yeah. No.
I want to add, if you don't mind, there's so many great things that you unpacked for us there. First, about the personality fit. You can be as introspective as you would like to try to figure out what your future career path will be. And I don't think you ever really know until you actually rub elbows and you're sharing life with that group of people. And another theme is just that, it's kind of overstating here, but the identity crisis that you had during your fellowship training, and that there's so much identity formation, each day as a fellow and even as an attending. Part of the process of developing is just continuing to remake and rebuild and emphasize more on what you like your career to become. And then I love the mention of you're around these complex cases. And I think there's so much benefit to when you notice complexity, you notice difficult cases, leaning into those things can benefit you in so much. I feel like so many times in the ICU that there's ways to take the hard route and maybe the not so difficult route. And it sounds like you really leaned into those cases, and that really helped guide your professional development. And then the search for mentorship. If you don't see it in front of you, you got to blaze your own trail. You got to figure out a way to support yourself and give yourself the tools you need to make a meaningful career. So kudos to you for all the great work.
Oh, thanks. I mean, I got really lucky in that having Laura Shekerdamian as my critical care chief, she's a tour de force in and of herself. And I think because she kind of went a roundabout way to get where she was super supportive and open to letting me try to figure it out. And then, people like Jeff Feynman at UCSF, for anybody who doesn't know Jeff, he is the kindest, most wonderful gentleman on the face of the earth. And he is an intensivist and a cardiac intensivist, but also does PH. And so I kind of cold emailed him out of the blue and was like, hey, I'm this random guy in Texas thinking about this career, but I have no idea what I'm doing. Would you be willing to talk? And
Wow.
He wrote back in less than 10 minutes, was like, tell me when you're free. And kind of became, and still is, one of my, primary mentors in this arena. And that's just pure luck, right? Like Jeff didn't know me from anyone. And I got really lucky that he was so willing to kind of take me on, even though I'm quite a far distance from him and he had no reason to say yes, but he did. And so I think that's one of the cool things about the peds world in general, right? Like we're pediatricians, we're nice people in general. But then, the PH world is really small. The ICU world is surprisingly small. And so, I think I would encourage all the fellows out there who are trying to find their way, like, don't hesitate just to send that random email because you never know, right? The worst they can do is ignore you. And the best thing that can happen is you find a guy like Jeff Feynman who builds a career for you from 1,000 miles away and, gave me opportunities that he certainly had no obligation to do by any means, but he did. And, I wouldn't be where I am without folks doing stuff like that. So, it was eye-opening for me. It's changed how I view, mentees now. I'm old enough, which is scary to have those. But also, I think it's a good reminder for all of us, like when somebody reaches out, like just say yes. You never know.
Oh, absolutely. Now, before we get started with today's case, do you have any relevant conflicts of interest that you need to disclose?
I do not. Like most pediatricians, unfortunately, we don't get conflicts of interest like the adults. So I've got nothing to disclose.
Sounds great. Alice, give us our case. Let's get going.
All right. So we've got a previously healthy 16-year-old who presented to the ED with syncope and leg pain. He was found to be hypotensive and developed worsening hypoxia. CT is diagnostic for a large pulmonary embolism. Fluid resuscitation is started for hypotension, and he started on high-flow nasal cannula due to desaturation to the mid-80s. He is admitted to the PICU for further care. Zach, you know how to write a case, tachycardic, and I'm already downstairs. I'm already in the ED. What do you mean? So we've given you a case really concerning for a high-risk pulmonary embolism. Thinking back to our previous episode on pulmonary embolism, high-risk or massive PE is commonly defined as a hemodynamically significant pulmonary embolism associated with cardiovascular collapse, hypotension, or shock. So these patients, when you have time to look, they have abnormalities on echo, brain natriuretic peptide, and troponin, but the classification is really clinical, and it's based on your hemodynamic assessment. So with this background, let's talk about the pathophysiology of high-risk PE, starting with what it's doing to this kid hemodynamically. How is this large PE affecting the cardiovascular system?
Yes, when I read that case, we all have flashbacks to that kid, right? The teenager with, down here we've had multiple ones that are, some new diagnosis, cancer, right? Prothrombotic, and here we go. With PE, I think, right, the big thing is this is obstructive physiology, right? You are blocking the PA. You have a twofold effect, right? Because you lose forward flow in and of itself, right? There's a traffic jam. But then when you think backwards to what it does to the RV, right? Like that's where things get really messy. And I think that's where sometimes people underestimate the power of interventricular interactions and just kind of the effect an acutely stressed RV can have on the LV. And so you get this big dilated RV suddenly that's facing this pressure load that it doesn't know what to do with, right? And if we think about how the RV is built, right, it's not built for this. It's got 2 muscle layers, the LV's got 3, right? The way it contracts is more like a bellows formation rather than the LV that's got that really strong concentric layer that can push through high pressure. So the RV is way out of its element. You get the RV that acutely dilates, you get really bad tricuspid regurgitation. So now you've got backward flow. So not only can you not go forward, everything that you do get there is going backward. The myocardium is under huge amounts of stress, right? Because physics was almost the reason I didn't get into medical school. So I am not by any means a physics person, right? But if you think about wall stress and tension, right, the bigger and more dilated you are, the more that myocardium is going to be demanding more oxygen because the stress is higher. And so it just becomes this vicious cycle that, it's the death spiral that these kids can get themselves into. And so, really figuring out how to try to unload that pressure loaded RV as quickly as possible is key in these circumstances, right? But it's hard to do, especially if you've got a thrombus sitting there. And I love that you guys brought out how important a clinical diagnosis is, because at the end of the day, like, who cares what the CT shows you or who cares what the echo shows you if the kid in front of you has hemodynamic collapse? Like, it doesn't matter. You know, one of the things we learned here when we were trying to develop our PE response team and how to handle these kids was people were getting so into the weeds about massive or submassive, or like, how do we classify the PE? Like, it doesn't matter, right? Because if the kid is an extremis, who cares? That point is super important. And I'm so glad you brought it up like early, because everybody forgets that, like, we can get so caught up in the academics, but it doesn't matter if the kid is falling apart in front of you.
So helpful if you emphasize those things. Perhaps to the novice trainee, when they start thinking about shock, it's easy to become like focused on the left ventricle. But if clearly this is a disease that at least originates with right-sided heart dysfunction, and you described when there's obstruction of the pulmonary artery, you're going to get dilation and decreased systolic function of the right ventricle, and you might get regurgitation through the tricuspid valve, blood flow going back to the RA. But you also mentioned this really key term of interventricular interactions. And I think this episode might end up dropping after the start of the new academic year. And so there might be trainees who this might be the first time hearing this term. And it's always good to remind ourselves. Will you tell us more about how this RV failure distinctly impairs left ventricular function in patients with high-risk PE?
Sure. So this is like my favorite topic in all of physiology, I think, because I do PH, right? So I live in this world. But I completely underestimated how important that interaction between the left ventricle and the right ventricle can be on a daily basis, right? Any disease state, it's particularly exacerbated in acute pressure loads to the right side. Everyone, like you said, it's all about the LV, right? It gets all the glamour, right? But behind every good LV is a better RV. And so when you think about the RV and you think about the interventricular septum, there's really cool data, especially when you look at muscle fiber tracking that folks have done, where you look at the way fibers cross. And so when you look at the RV and the way it interacts with the LV, those fibers cross in the interventricular septum. And what can happen is if you have an RV that gets really dilated or pressure loaded, it will impinge on that interventricular septum, and you'll get paradoxical motion of that interventricular septum, where in systole, where the LV is supposed to have the higher pressure, that interventricular septum should go from left to right. But in this circumstance, that interventricular septum gets shifted from right to left. And so not only do you have decreased blood flow going through the pulmonary vasculature to come back to the LV, but you have an LV that's being impinged upon and pancaked such that it's got a high end diastolic pressure, right? And that's going to impede the amount of blood that can get from your left atrium to the left ventricle. And as such, even if you don't have a mechanical obstruction like you do with an embolus, if you have just pure pulmonary vascular disease, that interventricular shift will decrease your cardiac output in and of itself. So even if you have a full cardiac output going and nothing's obstructed, if that interventricular septum is shifted over rightward into the left ventricle, you're not going to fill well. You're going to impair your venous return, and then you're going to have decreased cardiac output in and of itself. And so that interaction is so key to how you manage these patients, whether, again, it's PEs, pulmonary vascular disease, remembering that interplay of the interventricular septum and the two ventricles, right? And this, I think we'll probably get into it later, right? But it goes into how you choose your inotropes. It goes into how you choose your vent strategy. It goes into how you choose your volume resuscitation in these patients, because that interaction can be dramatically impacted by your choices and can actually end up hurting you rather than helping you if you're not careful. I think a mistake that all of us made when we were fellows, and as attendings now we see fellows make when something like this is happening, and the first thing you want to do is give volume. But sometimes that's the worst thing you can do in this circumstance because of this interventricular interaction and where the RV's at on its Starling curve. And so it's really cool physiology, but you got to be careful, and it's not intuitive. And so this is where I think a good understanding of how these interactions interplay and how resuscitating the failing LV can be very different than how you resuscitate the failing RV.
No, that's excellent. We'll link to a manuscript that shows a figure of this RV death spiral, how RV failure leads to LV failure, which of course causes decreased cardiac output, decreased coronary perfusion, and then the cycle gets back on itself with more RV failure. Fascinating stuff, and I think it really sets the agenda for our conversation, Alice.
Yes. And while we're talking about the RV death spiral, a novice taking PICU admission calls might think, I don't know, this kid's on high flow, which we do on the floor, and they may have responded to a fluid bolus. Like, why is my attending running downstairs? Why do we care so much, even though he's not intubated and he's not on vasoactives?
Yeah, I mean, so in general, for kids with pulmonary hypertension, right? So if we look at a stressed RV, the PICU mortality can run 8 to 10% or higher as compared to the traditional 2%. That's not in the setting of PE, so take that with sort of a grain of salt within the context of a PE. But for PH in general, it's a much higher mortality rate if they get admitted to the PICU, and it only goes up as you add interventions. There's a really nice paper out of San Francisco. Jeff Feynman is the senior author, where they specifically look at mortality rates in PH versus general PICU. And it can be pretty staggering, right? Because it's RV failure leading to these mortalities. Completely underestimated, right? Because again, everybody thinks about the kid in heart failure with a dilated cardiomyopathy, but nobody thinks about the RV and just how dramatically it can impact your mortality.
Alice, your point is well taken, is that there's just a fallacy here to think about your criteria for ICU admission being completely dependent on the current support being offered to the patient. And we cannot forget, what is the diagnosis? What is the suspected trajectory of illness? And a kid with pulmonary embolism has hypotension, after 2 fluid boluses. The answer is not to give them a 3rd fluid bolus and call me back. Like, it's get them up to the ICU now so we can figure out what's going on, what we need to do for this kid. Let's transition to the pulmonary system. So, these kids become hypoxemic from a number of mechanisms. Will you kind of overview how a large pulmonary embolism affects the lungs?
Sure. Another thing that I think, at least from my personal experience as a fellow, right? You hear people talk about VQ mismatch. What does that mean, right? Like, is it actually that big of a deal? But in these diseases, right, this is where it becomes the big deal. Because with PEs, right, you get impaired pulmonary blood flow, right? So you're trying to oxygenate potentially an area of the lung where there's just no flow, right? And so these kids get hypoxemic. You get progressive VQ mismatch worsening, which then portends more hypoxemia. You get hypoxic vasoconstriction, again, trying to maximize the VQ matching where you can, but that only contributes to further increases in your PVR over time, especially if you've got a big PE that's taking out a good portion of the lung. And so again, you get into this vicious spiral of more hypoxemia begets more hypoxemia, and the thing people reach for, right, is turn up the high flow, right? Give them more high flow, high flow, high flow, high flow. But there's no blood flow, right? So you can have all the high flow in the world you want, but if there's no blood flow, it doesn't matter. Again, you get into the hemodynamic worsening with the increased metabolic demand on top of the hypoxemia, right? Here comes your lactate, here comes kind of all the bad things that happen in this state. But again, as you guys mentioned, right, it's not more fluid and turn up the high flow in this particular circumstance. Like, if you're needing more high flow, you have a huge problem on your hands and you better get moving.
This really gets at what's the mechanism of hypoxia in your patient in front of you. And I guess maybe a word for roundsmanship for the first year fellows. If that question comes up on rounds, it's probably VQ mismatch because there's so many different types. But this is a situation where these kids are tachypnic and they usually have excessive amount of ventilation, but there's going to be a very low perfusion, especially if a lot of the pulmonary arteries are occluded by a thrombus. Thinking more about the hemodynamic assessment of these patients, you've already mentioned lactate. What comes to mind as the essentials of what you would want the emergency department to start, or would be your immediate priorities when they land in your unit?
PE is a tough one because it's such an acute event usually, that sometimes the labs actually look relatively normal depending on where you are in the course of the PE, right? Like if they've had time to start bumping a troponin or they're, so things like troponin, BNP or NT-proBNP, depending on your institution and whatever your flavor of BNP is, a blood gas with a lactate, and one where people will say, oh, well, there was a tourniquet on it, so that lactate's probably not real. It very well might be real, so forget the tourniquet. But those labs, I think, are important. You can send some of your things like D-dimer, your coag panels to look at your INR and those other things, CBC, so you know where your hemoglobin is and like how low are your platelets as you're trying to get a sense of, again, where am I at in the spectrum of badness that's ensuing. But I think a gas and a lactate, and eyeballs on the kid. I think this is where, again, labs are kind of helpful, but they can also deceive you depending on where the kid's at in the setting of their PE. And so a good exam, I think, trumps almost any laboratory finding. I'm curious what you guys think, and if you have a different opinion. Obviously, I'm certainly open and I'm wondering what you think. But to me, like a gas and some of those things are helpful. But again, your exam is more important than almost anything in this circumstance. Your spidey sense or the hairs on the back of your neck or whatever you want to kind of use as your euphemism of choice. But that really, I think, is key. Otherwise, you might find yourself fooled.
No, it completely resonates with me. Like in the case we're describing for you, you don't need blood work to tell you this kid is sick and needs an escalation in their care. Of course, if there's a lactate present, be evidence of shock there. If you had NIRS on the patient and they were quite low, that would be worrisome for shock. If they're tachypnic, that's probably suggesting that they're maybe acidotic as well. And then, mental status, urine output, all those normal things that we would look for shock. But as you described, this hyperacute nature of this presentation, some of those might not be present quite yet. Or there'd be better ways to identify how sick this kid might be.
I think that, right, if it's like the right main pulmonary artery and the child's in shock, then it's not a question. But for some of the segmental, subsegmental clots, I don't hate having a brain natriuretic peptide and a troponin to calm me down. If it's medium or normal, then it's fine. And then if it's significantly elevated. But in a hospital without a PERT team or any structure surrounding the PE process, and I don't hate the hard data.
Yeah, no, absolutely. And I think, we all send those labs. And I completely agree with you. Like, I love a BNP. And I think troponin is super helpful. If it's some of these kids with, like you said, the subsegmental, they're gradually getting worse and gradually getting sicker on you. Things like LFTs and a creatinine to sort of figure out like where are they at from a chronic end organ standpoint can also be really enlightening in those kids. We see it in the PH world, like with chronic thromboembolic PH. It's not super common in peds, thank goodness, like being honest. But that's where you see a similar presentation. Like they've just got that smoldering stress on the RV. Their BNPs are high, but they're not too high. Their troponin's just a little bit up. And you're like, wow, that was really frustrating because it didn't give me the slam dunk diagnosis, but it didn't take it away either. So I completely agree with you. I love the data. But this is one where, when a fellow gives me a call and says, hey, the ER's calling with this, I'm like, why don't you walk down there? Like, I want to know what you see on top of the data they give you. How hair on fire do we need to be with the situation? But completely agree with you, Alice. Like those hard data points are super helpful, especially if you're trending over time to figure out timing of the cath lab or what you're going to do, like which way are they going, up, down. They're really helpful over time.
Let's imagine we're taking care of the patient in our case who's clearly sick. Everyone identifies the child as sick, not crashing, i.e. not like peri-arrest. Say they're bringing them up to the ICU. We've already let cardiology know that we would very much prefer their assistance in echo. And you're looking at the CT scan. Tell us about how you might infer right heart function, either on a CT scan and especially when that echo tech shows up, what you might look for on the echo.
Sure. So, I think CT is helpful to delineate where the thrombi are. Like you said, are they, main PA? Are they getting out into the distal segments? CT can show you how dilated the RV can be, which is helpful. But to me, echo is where the money lives with trying to figure out where to go with the PE patient. As soon as that probe hits the chest, first thing I want is the 4-chamber view, right? How dilated is that RV? If you've got time, right, depending on the acuity of the patient, this is where things like measuring RV strain, looking at your TAPSE or tricuspid annular plane systolic excursion, right? Like how much is that RV able to move and contract can be helpful. This is where there's the really fancy signs on echo, like the McConnell sign, right? Which is, relatively pathognomonic for PE. So the McConnell sign is where the RV free wall stops moving, basically because it's so pressure loaded and stressed that it kind of gives up, but then the apex is preserved. You really only see that in something like a PE. You don't necessarily see that in like chronic pulmonary hypertension. That's an acute finding. This is where paradoxical septal motion comes in. Again, what is that interventricular septum doing? And so that's where you go to the parasternal short axis, right? And you get what should traditionally be your sun and moon view with the nice round LV on the bottom and the crescent-shaped RV on top. But is that what you're actually seeing? Or is this one of those where now you've got this big dilated RV sitting on the top with kind of this poor pancaked LV at the bottom? You get the D sign or the inverted D where that interventricular septum goes flat or actually inverts towards the LV, right? So those are things where just those two pictures, right? A nice 4-chamber view and peristernal short where you can see just how stressed that RV is, that is all you need sometimes to make a clinical decision about like, do I need to go, right? Do I need to get the cath team in here? Do we need to like figure out, are we going to give TPA? Or like, what are we going to do? A pretty quick look with an echo probe, I think, really is important in these patients. You know, sometimes you have to call and beg and plead at 2 a.m., right? And the poor cardiology fellow has to come downstairs and do the imaging for you. But, you know, that's key to these kids and this diagnosis.
What I'm hearing is that echo is essential. This is the time, if this kid is really, really sick, to get the echo, get that probe on the chest as soon as reasonably possible. And it sounds like there's a qualitative assessment that you can gather relatively quickly to see if the RV is failing. In our kids with chronic pulmonary hypertension, it's common that the cardiologist will measure the tricuspid regurgitant jet to give us an estimate of PA pressure. Do you find that that's relevant in this acute scenario here, or is that more of something we use for chronic kids?
So I think it's both. It's tough, I think, in some ways, because it depends on how impacted your RV is by the event that's happening. It's interesting, right? Because we talk about RVs kind of more in the PH world, but it applies to this too. Kids with what looks like relatively poor RV function, right? Like the thing looks like it's barely moving. I joke that it's kind of like the white man at a bar, right? It's there, but it has no rhythm and isn't doing much. Saying that obviously as a white man. But then it generates systemic to suprasystemic pressures, right? Which is always kind of the oxymoron of failing RV, but generates suprasystemic pressures. But conversely, sometimes you have the RVs that are failing and don't generate suprasystemic pressures, at least by TR jet. And you can see either one, at least when I look at our chronic PH patients, you know, and I worry more about the kid that's got the big dilated RV that doesn't move and is no longer generating systemic to suprasystemic pressures when they previously were, than I do about the kid with an RV that, again, isn't moving very well, but still somehow gets suprasystemic. In PEs, I've seen both, where like the RV, there's not a lot of TR jet because there's just not a lot of squeeze to generate the pressure load because the RV just acutely said, what did you do to me? But then sometimes you do see suprasystemic pressures with the RV. So I've seen it both ways. I'm curious what your guys' experience has been, but I've seen both ends of the spectrum here.
Ryan, this is such a low frequency event for me that I would be calling mentors. This would be something that I would have people more senior than I helping me think critically about this patient. By kind of reading between the lines of what you said there, it seems like this acute load on the RV might be unique compared to the kid who has chronic RV dysfunction. And there might be something a bit more precarious or scary about it. Does that resonate to be true?
Yeah, I think you're absolutely right. Sometimes when the RV gets acutely stunned, it just stops moving versus where it has some time to chronically adapt in more traditional pulmonary vascular disease and can kind of hang in there. And that's where you see the McConnell sign where like that middle just stops. The apex tries to keep going, right? And you get some benefit from the LV pushing over. Yeah, so you get some benefit of the LV dragging the RV along with it because of the way the interventricular septum is made up with both LV and RV fibers. So you can compensate to some degree, but again, TR is hit or miss in the setting of PE. Also depends on the volume status of the patient and how much flow they're getting. I find that the configuration of the RV in terms of its dilation and positioning can be more helpful in this circumstance than the TR jet in and of itself.
Oh, well, thank you. That's very helpful. I had never thought about the TR jet in that way before.
So I think we'll now kind of move more into like the hemodynamic support and resuscitation of these patients. Alice, you want to update our case?
Let's do it. All right. So our 16-year-old with the newly diagnosed high-risk pulmonary embolism has evidence of ongoing shock with hypotension and elevated lactate, troponin, and brain natriuretic peptide. Echo is notable for RV dilation and decreased systolic function. He is now status post 1 liter of fluid and is on high flow 40 liters, 100% oxygen with saturations in the low 90s. He received a heparin bolus and continues on a heparin infusion. Definitive therapy, including systemic thrombolysis or mechanical removal, is currently being discussed among a multidisciplinary team. So if you're at the foot of the bed here, can you tell us what your general goals and next steps for this resuscitation are? What are you doing for respiratory support? What are you doing for hemodynamic support? I imagine you're calling some meds to the bedside.
Oh, yeah. So again, it's one of those where I freely admit I have a bit of a bias when it comes to things like high flow nasal cannula, and that I don't like it up to a certain point. I think people really get comfortable with these massive amounts of flow and like just keep turning that knob, and you forget like This patient, for example, and it's not an uncommon scenario where suddenly like you get this phone call and like, yeah, they're on 40 liters. I'm like, what on earth does that even mean? Right? Like, what does that translate to? Like, I have no idea other than you've got a big problem. And so if I were to walk down and see this, right, I'm getting ready to intubate because this is not sustainable, right? And if you wait in this kid until their SATs are in the 80s, you're going to be in big trouble. And so this is where, like you said, you're getting meds drawn up. I personally really like ketamine in these patients because I think you maintain your SVR. You don't get the drops in your systemic vascular resistance like you do with benzos, for example, though this might be my training bias showing, because I know different institutions feel differently about sedatives, but I really like ketamine in this circumstance. I know at one point there was concern that ketamine would actually increase your PVR even further. It may not be a good drug of choice, but those data are really mixed to not true. And I can say at least anecdotally, so take it with a grain of salt, we have not had problems with ketamine in this type of patient. So this is where a quick induction, right? This is not where you mess around and give, 2 mics of fentanyl, and then you wait and you watch, and then you give your midaz and you like none of that. This is where you give a good dose of ketamine, like 2 milligrams per kilo of ketamine up front. You've got your second dose ready. You've got your paralytic ready to go. You don't necessarily have to do a true RSI per se, but like this is one of those quick induction, get them to sleep. You don't want them in that window of hypoventilation, right? Their PCO2 rising, getting more acidotic than they already are, because that's only going to raise your PVR even further. And so quick induction, be ready. Depending on how much time you have and where things are at, I love a low dose epi infusion in the background for these patients before we actually induce and get ready to intubate. So my voodoo dose is 0.02 per kilo. I think that's like a little something, but not too much. So I love epi going for 10 to 15 minutes in the background if you can. I like to have a vasopressin infusion available as well for these patients. Again, if you think about interventricular interactions, you use your epi for some squeeze to try to help the myocardium. I use my vasopressin for maintaining my SVR and to try to keep that interventricular septum shifted back over to the right as much as possible. I love that combination. It is my favorite go-to. Epi-vaso makes the world go round in my world. And so those drips, if I need them, I like them going. Then, like you said, you get people to the bedside. This is not an intubation for a first-year fellow. This is an intubation for either a senior fellow or, quite honestly, I call anesthesia for these. Even cardiac anesthesia, because then it's a 2-for-1, right? Because you get the hemodynamic awareness that those guys have, plus anesthesiologist hands. This is a one-attempt intubation, right? You don't want an esophagus here. You don't want somebody futzing around, having trouble finding the cords. Like, the risk is so high in this circumstance, right? And if you think about the physiology you're about to shift this patient to, from negative pressure ventilation to positive pressure ventilation, right? That's going to be a big change for the RV in and of itself, right? Because while the LV views intubation as an inotrope, right? You raise your intrathoracic pressure, it's easier for it to eject, right? The opposite is true for the RV, right? You're going to increase the afterload that the RV is up against with positive pressure ventilation. If you're not careful and you inadvertently go above your FRC, right? And you think about that deer curve that will haunt us all for the rest of our lives, and it's on your boards about your FRC curve versus your volumes. You don't want the kid hyperexpanded, and you don't want to take so long that they get atelectatic either, and then you lose lung, and then you shift the other way on your curve, but either way you hurt your PVR. Quick induction, meds ready, right? You have your code meds drawn up before you ever induce this patient. For these patients, I try to avoid full dose epi doses if I can. Here we call them epi spritzers. Different institutions call them different things, but diluted dose of epi, basically where you don't hit them with the whole thing, but it's like a little bumps of phenylephrine that the anesthesiologists talk about. Because if you give a full dose of epi, right, you will affect your PVR as well as your SVR. But if you give kind of these smaller doses, maybe you can get a little bit of contractility without that full PVR effect. So I'll have epi spritzer doses drawn up. I will have some bicarb ready, because again, any amount of acidosis is going to worsen your PVR. So this is where I am a fan of bicarb, not always a fan, but in this particular circumstance, I am. Careful with the fluid volume, or fluid boluses here, I should say. I think this is a pitfall that, again, kind of as a fellow, you do it once and you learn your lesson. And then as attendings, you keep your eye out for. But kids with PEs or acute pH crisis, for whatever reason, If that RV's already distended and the patient gets hypotensive and you hit it with a big fluid bolus, you're only going to further distend that RV, and whatever contractility it might have is now gone. And you'll see the kid go from some hemodynamics to no hemodynamics following the fluid bolus. And so I do not give fluid in these circumstances. I rely on epi. I'll give calcium. I love calcium in these circumstances to increase your contractility without a negative impact on your PVR, SVR. So I've got all the things ready, right? This is where you've got that bedside table with all your drugs lined up before you ever do anything. And then ketamine, a whiff of fentanyl and Versed after the induction and after the tube is in. But honestly, I'm a ketamine and paralytic kind of person for these kids. And then you apologize on the back end with the Versed, but get that airway and keep your hemodynamics.
This seems like the quintessential, like, resuscitate before and during while you intubate. And it sounds like in many scenarios like this, you're staying far away from additional volume because it's almost imperatively this kid's going to get volume before you see them, like either by EMS or by the emergency department, as far as just a general assessment of and treatment of shock. But it sounds like early vasoactives, titrating an epinephrine, probably for right ventricular support, and then vasopressin, because I would imagine that's probably the vasopressor that you feel like would not negatively impact the pulmonary vascular resistance. Is that correct?
Yes, and there's one published paper, it's a little bit older now, that showed in the cath lab that vasopressin has a PVR lowering effect. There's not a ton of data out there, but it gives me a little more ammunition when we're talking about vasoactive choice at the bedside, because not only do you maintain your SVR, but you very well may have some positive impact on your PVR with that drug. So I said for my patients, epi-vaso is the go-to.
This is a scenario that I think really is a test of the intensivist communication and team leadership skills. Do you have any pearls here about how to optimize the shared mental model or team dynamics when you're preparing to intubate a patient like this?
Sure. I certainly have some thoughts about it. I can tell you that kind of when I'm at the foot of the bed with these patients, I'm very clear about my concerns about the RV and try to very carefully delineate that in this particular patient, the RV is the game changer. And so the resuscitation of an RV is very different than the LV. So I try to kind of keep that at everybody's forefront and say it over and over. And, I'm very clear about we are not giving volume because if we do so, we may push the RV off of its Starling curve and end up with worse hemodynamics than we have to begin with. I'm very clear about my choice of pressors and exactly what I'm going for in this circumstance. Because I think when people hear epi, right, it's for the LV, right? You're improving LV contractility, but that's not what I'm using it for here, right? I'm intentionally targeting kind of my thought processes towards that RV and wanting to help it without getting too high on the dose, because I don't want to induce tachycardia, right? Because you're in a state where you're already not feeling well. And so if you increase the heart rate, you're going to only further impair your diastolic filling. You're only going to make your hemodynamics worse. So I don't want to get a huge alpha effect. I don't really want to jack the heart rate, with a beta overload. Like I really just want to be thoughtful and mindful of what I'm doing and why I'm choosing it. And so I try to be very, very intentional and a lot of thinking out loud, making sure that the folks in the room understand why I'm doing what I'm doing, and then being cognizant of the trainees in the room, right? You're trying to balance letting them get some experience, but at the same time, not putting the patient at risk, right? And everybody's got feelings when they aren't allowed to do the procedure, and especially when they aren't allowed to intubate. And so I also try to be incredibly clear with my reasoning for who I want to actually put the tube in this particular circumstance and why it's different. Because I think otherwise people are making assumptions that I don't think they're skilled or I don't have faith in them. And I don't want that to ever be the thought, right? Because we know what it's like when you're a trainee and you're constantly under the gun and you've got that feeling of my attendings judging every move. And so I just want to be clear that it's the patient's fault. It's not your fault. And I'm trying to minimize the amount of time in the airway. So I think just being really clear and emphasizing the points over and over again of why this is different.
Oh, yeah. It is one of those things where the patient may arrest during induction. Despite everyone's best efforts, it's best that the anesthesiologist is the one intubating at that time for your trainee. Yeah.
Correct. And it frees you up, right? Then you're free to run the resuscitation and the code. The anesthesiologist just has one job, and that's get the airway. And so it's a good division of labor. with different focuses or foci of each attending in the room.
I want to ask, we didn't touch on nitric oxide or other inhaled pulmonary vasodilators. Is that something in this patient, say they already had it or it was close and you were taking the airway, would you start that through the high flow circuit prior to intubation? Would you wait until after intubation? Do you think it's not beneficial? What's your practice here?
I think it's a little bit of dealer's choice in this circumstance. I mean, any amount of help to the pulmonary vasculature is a good thing. So I don't think there's any harm at all in starting nitric whenever you choose to, in whichever way your teams are comfortable. I think sometimes if you start it before the intubation, you have to be careful about bagging with nitric and making sure the transition happens, because you don't want to acutely take away the nitric inadvertently for, the 7 alveoli that may be really appreciating having it around. So I think it's a little bit of what your team is most comfortable with. And, do you want to just get the kid intubated and then start the nitric afterwards? But I do use it, again, knowing that in the setting of a PE, I still have a mechanical obstruction that nitric's not going to address. But, if it's 7 more alveoli, it's 7 more alveoli that may get me to the cath lab, in a little less of a blaze of glory. So I would definitely go for it. But I think it's a little bit of a systems comfort level as to when you choose to start it.
No, that's great. That's great. I mean, anything that you can do to optimize this patient to prevent a cardiac arrest and get them to the definitive care they need. So maybe progressing our case along, say with the excellent communication and resuscitation, tube goes in, you're able to mitigate a cardiac arrest from happening. But even after optimizing FRC, optimizing oxygenation and starting nitric and your vasoactive resuscitation, there's still evidence of shock. And you're still working with a multidisciplinary team for definitive care of the thrombus, but you're worried that this child needs additional support. What might be your next step?
So ECMO. I am a big fan of early ECMO in these patients. Again, I think as intensivists, right, you practice off that N of 1. Like you remember that one kid where things really went sideways and you don't ever want it to happen again. I can certainly remember a case of a kid here where we were kind of back and forth about the hemodynamics are okay-ish. We got him intubated. We're not falling apart. We're still trying to decide, do we really want to expose them to the risk of ECMO? And we spent too much time in the pondering what ifs world, and the kid fell apart on us, and I thankfully did okay in the end, but it was way worse than it needed to be. And I think early ECMO in that circumstance, right, you're already anticoagulating these kids. In this case, you've already started your heparin. In most cases, you've given something. So the risk of anticoagulation is there. So give them the hemodynamic support while you're at it. And so here, when we built our formal PE response team, part of that initial call out tree is ECMO up front, because we want that circuit and the surgeons ready to rock and roll early and have a very low threshold to go on. Our cath team is very comfortable cathing on ECMO. And so they don't ever push back about the kid already being on a circuit. So we try to coordinate access with the cath team if possible. If they really feel strongly about wanting the right groin as their access point, can we cannulate on the left? Or depending on the patient's size, do we go neck and leave the groin for them? We try to coordinate, but we're pretty early and aggressive with ECMO, because then you don't have to worry about the arrest. And when you think about what's going to potentially happen in the cath lab with those catheters crossing the tricuspid and irritating an already irritated RV, the chance of arrest is so high that it honestly, I think, makes the cath safer and gives them a little bit more time to be mindful with their procedure without trying to rush, and deal with up and down hemodynamics, trying to get the thrombus out. Is the kid tolerating it or not? Then are you suddenly in the setting of needing to activate eCPR in the middle of the cath, and a bad situation goes from already unstable to a dumpster fire? I'm definitely a proponent of early ECMO, get them there. If the circuit stands in the room and the surgeons are bored, I call it a win. So I like ECMO early. Again, at the end of the day, if the kid went on ECMO and gets off ECMO, great. I don't think there's a downside in this case to sort of cannulating early and avoiding the shenanigans.
So it seems like a pitfall here is to think your hemodynamic support is removing the thrombus. And when in fact, it seems like with your experience, getting that hemodynamic support secured with ECMO in a case similar to this might be beneficial compared to risking them decompensating in the cath lab.
Absolutely. I think these patients are that unique subset of kids where you can make them look better, but they're not actually better. To your point exactly, like you can fix the hemodynamics a little bit, right? You can get that lactate from 5 down to 3, right? With intubation and good hemodynamic support, but your thrombus is still there. You have no idea the acute nature of it. How adherent is it? Are you with your heparin infusion going to knock it loose and then it moves to a more precarious position than it was in before? Like there's so many unknowns that I think early support, especially when you get into that more massive category, like just do it. Like err on the side of good support, get to the cath lab in one piece, and then we've had kids where you even decannulate in the cath lab once the thrombus is out, right? These are not necessarily prolonged ECMO runs, because once that acute volume load is taken away, or pressure load really from the RV, it usually is going to rebound relatively nicely. So you're not committing these kids to a week, 2 weeks of ECMO, right? This may be 6 to 8 hours of ECMO just to get through that procedure. And then wean your flows in the lab once you've got the thrombus out and see where you're at. Here, we've been lucky in that as our ECMO program has matured over time and we've gotten a little bit more facile with more challenging patient populations, this idea of peri-procedural ECMO support, we're becoming more comfortable with. And so whether it's a PE or kids with pulmonary vein disease that need a high-risk vein intervention, putting them on support to get through the procedure, even if their hemodynamics are okay-ish, but you're about to kind of poke the bear with your intervention, like it's not necessarily an evil to use ECMO as kind of, I'm not waiting for the kid to crash and burn, I'm just using it as peri-procedural support, no different than inotropes in a ventilator. And then once I get through the intervention, wean my flows back down and see where I'm at. So I think it can really be a nice tool that sort of changes how we think about ECMO in general, right? Like it's not a therapy of last resort anymore, but it's a ventilator, it's an inotrope, it's something else to have in our back pocket to make this procedure safer and keep the patient more stable throughout.
That's really an important push, I think, because that wasn't the way that I was thinking about it for kids in PE previously. How would you respond to someone who said, we don't know why this 16-year-old previously healthy kid clotted his pulmonary artery. Isn't he just going to clot the whole circuit and then stroke?
Sure. And those conversations happen, right? And my honest answer is, I don't know. I don't know if he's going to clot the whole circuit. I have no idea what he's going to do. Being a bit flippant for a second, but we're intensivists, right? We have a little bit of a dark side. You got to be alive to clot off something else. And so you've got to get through that acute period before the hypotheticals and theoreticals can take effect. And so that's the conversation I have, is like, it very well may happen, right? And if it happens, we have a big problem, right? We had a patient here not that long ago that was in such profound DIC that they clotted off multiple ECMO circuits. We tried to get him on a bypass circuit and they managed to clot that off too. And unfortunately, that patient passed away. Like, it may happen. And if it happens, that's the fun of being an intensivist, right? You just deal with whatever keeps getting thrown at you and you throw something back at it. And so I would say, like, we're going to give the kid the best shot we've got. And if they do it, they do it. And that may declare itself on the other side. But I think it's rare in general that we don't have a decent sense of where this thrombus, or like what made the kid more at risk for the thrombus, right? So, like I said, here, our big ones seem to be teenagers with new cancer diagnosis, testicular cancer. We've had multiple kids with testicular cancer in PEs.
Oh, wow.
I think it's maybe a weird TCH thing. Because
they come in threes or something. Yeah.
But like you can usually get to a place where you can figure out where it's coming from and go after that etiology at that point. We had a teenager not long ago that had chronic thromboembolic pulmonary hypertension that on CT was found to have multiple subsegmental PEs after presenting with tachypnea and a bit of hemoptysis. And so went to the cath lab thinking it was just going to be kind of subsegmental, we'll just get a few clots out here and there, no biggie. But when they measured his pressures, like he had evidence of actually ongoing pulmonary vascular disease. And turns out he had newly diagnosed lupus. And his mom had lupus. And, like we were able to kind of piece together what made him prothrombotic. So I think you can usually figure it out. And so I would say, I'm sorry, but we're going to go for it because it's the only way we're going to get to the place of having the luxury of figuring it out. And so you just got to take your chances.
I mean, much like everything else in critical care, you make the best decision with the information that you have at the time and you do your best by the patient in front of you. I was interested in learning more about this prior to our conversation today. I think of PE as obstructive shock. And so when I think of obstructive shock, I think of VA ECMO. But when I was reviewing literature, I saw the reports of using both VA and VV ECMO in patients with PE. Do you mind just explaining the immediate advantages and disadvantages of choosing one versus the other in patients with PE and like why might they both be able to support these patients?
So I will, again, admit my bias up front. For kids with a failing RV, for whatever reason, whether it's acute PE, chronic PH, I have a very strong bias towards starting VA ECMO up front. When you think about the physiology that you're trying to deal with, right, you're dealing with an RV that can't handle the volume load that it's being presented with for whatever reason, or pressure load, depending on what's happening at a given point in time. And so VV ECMO does nothing to alleviate that part of the equation, right? Because you're still reloading that RV. You're giving it oxygenated blood, so that, in theory is going to fix the acidosis and help your PVR to some degree. But it doesn't address the acute pathophysiology that got you to the point that you're in. And so I am a humongous proponent of VA ECMO in this circumstance because you unload that right side, you bypass the whole pulmonary vasculature, and you give yourself guaranteed cardiac output, right? So you're not trying to juggle a lack of cardiac output you can count on like you are in VV ECMO, right? Because VV, you still need that RV to pump. You still need blood to get through the pulmonary vasculature and load your LV. And so if you've got a thrombus, it's not going to happen. If you've got an RV that just can't do it anymore for whatever reason, it's not going to get blood through that vasculature. If you've got a constricted vasculature, it's not going to get blood through it. So I'm a big fan of VA ECMO in this circumstance and not even messing around with VV. I will say the only patient population where we still really debate this is with our congenital diaphragmatic hernia babies, because some of our pediatric surgeons are like, well, if you do it early enough, you can maybe get away with VV. And so I'm like, well, maybe, but I still want you to dissect down. I want you to put some sort of suture or something around that artery so you can quickly get to it if this doesn't work, because I just don't have enough faith in the RV to be able to get through it in one piece. And so I am not a proponent of VV ECMO in this circumstance. I would go straight to VA and just guarantee yourself an unloaded RV and cardiac output and not mess around with VV and then needing to potentially convert later.
It's very fair. Definitely sounds like an extremely advanced move.
And maybe just to flesh out the discussion for the VV ECMO, that I imagine the hope would be that by appropriately oxygenating the pulmonary arterial blood, you would get some pulmonary vasodilation. But it seemed like it's a razor's edge about which patient you can actually support with that versus just going completely to VA.
Correct. And I'm not a betting guy, and I much prefer the guarantee that VA ECMO gets you, yes, at a cost, right? You can't be naive about the risks of VA ECMO, particularly if it's a patient where you need to get into the neck to cannulate them, and the potential risk of stroke, and if you can repair the carotid or not. I don't want to come across as flippant about it or naive to the risk, but I think in general, the chances of going on VV and being inadequately supported are pretty high. And so I'd much rather VA up front, get your business done, and then get off ECMO.
Ryan, I suspect your answer to this might be that we don't know enough in pediatrics, but any experience either locally or through conversation with others on venopulmonary arterial support for ECMO, where you can give that right heart support but not subject the patient to the risk of stroke with via ECMO?
Yeah, so it's an interesting question in peds. When this got raised, I think my first encounter with it was during the pandemic, when you had these patients with horrific ARDS, right, that was causing everybody's RVs to fail. And so we started with this approach of, do we cannulate in such a way that we get the cannula out into the PA and bypass, the failing RV. I think there is a place for it. If there's a big thrombus sitting there, this is not the time to try to get a cannula past it. It's come up with some of our heart failure patients where you put in the Berlin or the HeartMate 3, or something to support the LV, but your RV is still really struggling. Do you do a true BiVAD? Do you try VPA ECMO and see if that's enough to help them through it? I do think there's a place for it. But to me, that place is only in the setting of right ventricular myocardial failure, People have tried it in the setting of pulmonary vascular disease, so like pulmonary arterial hypertension of pick a flavor, but it doesn't work in that circumstance because you're still trying to push blood flow through constricted vasculature that doesn't want it. You're just pushing it at a higher pressure, and so you get more hemolysis, you get pulmonary hemorrhage, you get torn up capillaries. Like it doesn't work well. And so kind of my experience has been for the kids with myocardial failure, it's a great tool. But I think otherwise, if it's pulmonary vascular disease, I haven't found it to be particularly helpful. That's also with the caveat of we haven't used it very much either because we don't have a ton of opportunity. Like I said, we used it in the pandemic when we were taking care of adults here that needed to go on ECMO support because you all remember what that was like. And the adult hospitals were overloaded, and so we were getting overflow. And then here at TCH, we have the Pavilion for Women attached to us. So then we had these peripartum women that we were trying to support as well. That was a learning curve I don't ever want to get back on again. But in those circumstances, it was a helpful approach to buy time, but only in that disease do I think it's helpful.
That's very fair. Ryan, you mentioned that Texas Children's Hospital has a PERT team or a pulmonary embolism response team, and that the ECMO team is included on the discussion for all of these PEs. This is important because Dallas has a PERT team, you have a PERT team, Emory, CHOP. Most children's hospitals do not have pulmonary embolism response teams, which means that when this high risk, low frequency event happens, you as the PICU fellow are in charge of piecemealing together all of these subspecialties as fast as you can. You probably haven't really thought about it prior. I'm curious how you trigger your PERT team and then who's involved in these discussions. And if you were looking at other institutions, who do you recommend that these PICU fellows reach out to urgently and sort of get the Zoom meeting together?
Sure. So we developed it out of unfortunate events, right? Like most things, necessity is the mother of invention. So when we had those teenagers that kind of kept showing up with PEs, like you said, we were piecemealing together, trying to figure out who was going to do it. And here, because TCH is the land of subspecialists, we had, a divide between our surgeons. Which surgical team was even going to cannulate these patients? Is it the cardiac surgeons because it's a failing heart? Is it the pediatric surgeons because these patients are not part of the heart center per se? And that's where the dividing line typically is drawn here at TCH. So we couldn't get it together really with how to do this in a thoughtful way. And so we put together a team that the PICU is in charge of initiating. So whether it's the PICU fellow or PICU attending, it's actually built into the system now. But so PICU activates it. Interventional cardiology, ECMO, congenital heart surgery are automatically called whenever these patients present. And hematology, can't forget the hematologist. So they are automatically part of this initial response. The idea is that you have the huddle at the bedside if it's during normal hours. If it's at 2 a.m., because everything happens at 2 a.m., then you get hematology on the phone. Here we have a separate ECMO attending. I don't know how different institutions do it, but that person may not be in-house, but you get them on the phone. We always have ECMO primers in-house 24/7. So the ECMO primer is part of this conversation so they can get the circuit ready ASAP, and you sort through it. There is a paper that was published in Chest a few years ago from our institution. Dalia Bashir is the first author. They kind of worked through how we got to where we are and what our response looks like, because we'd had so many kind of stops and starts along the way of designing what this team would be. Initially, there were even more people involved. Like we would get the pulmonary hypertension team involved because they were kind of the RV team that would kind of help sort this out, right? But really, you don't need the PH team for an acute PE. And it was just another phone call and another distraction from an acute process. So we took that out. And so those are the key players that need to be involved, that as soon as you know there's a PE, that team is activated. We have delineated in our protocol kind of what labs and imaging we want. So CBC, type and screen, NT-proBNP, your CT with contrast, echo, upfront imaging is the expectation as well. And this is like a non-negotiable. And so CT knows that this is a priority study when it's asked for. Cardiology knows that when we're worried about a PE, like we don't try to push off this echo to the tech that's going to get here at 6 a.m. or whatever, right? Like you just got to get down there and do it. I'm sorry. The echo attending needs to come in if the fellow is truly swamped and can't do it. Like we've set pretty high expectations that division chiefs are bought into to ensure that this process goes off. Because like you said, this is a low frequency, high risk, high mortality scenario. And so it's not the time for opinions or feels. This is the time to kind of do what you're asked to do. And that requires institutional support. And so that's kind of how we built our team, because like you said, it's too messy if you're the PICU fellow trying to navigate a bunch of people all at once. So now we have it just built into our call system that when you call our page operator and you say, I need the PE response team, there's an algorithm and it is followed and those teams are paged. And it's made a huge difference. And again, because we're the land of sub specialists, the other thing we were running into, like with our hematology oncology services, at one point it was combined. Now there's separate hematology and oncology, but that was a huge problem when this was coming up, because if it was the oncologist attending on, they don't do acute PE, so then they're calling somebody, and that was another layer of challenge. We had to do this because it was just, we're too big and too complex, and it was causing time delays and was not good for patient care.
No, I love it. Maybe one more follow-up question on kind of multidisciplinary collaboration. We've given you a case today where it seems pretty clear the kid needs to go on circuit. They had evidence of RV failure and worsening shock. A lot of times, though, it's a lot more gray. This kid has maybe some responding somewhat to your hemodynamic resuscitation and intubation, and that there might be a need for like this quote unquote ECMO on standby peri-procedure or during whatever this kid needs. It's easy to say that. It's hard to operationalize that. And there can be so many different layers of standby. And like an ECMO circuit in the corner of the room without a surgeon nearby is worthless. If you care to offer, like, what might ECMO on standby look like for your institution in a scenario like this?
Yeah, so I'm smiling because we just went through another iteration of redefining what the various levels of ECMO standby mean here. It actually started with our cath lab, trying to be clear with our cardiac surgeons who provide the ECMO standby under most circumstances. There's some where our general surgeons do the ECMO standby, but we had to clarify this. And so what we ended up with was ECMO aware. So that's where the ECMO team knows that there's a patient who's at risk of needing ECMO. And so they know, the patient's got a type and screen, we've got blood available. We don't have a surgeon like standing in the room. There is a surgeon in-house who knows of the patient and will come if needed. And the primer knows, but we don't necessarily have the circuit primed and sitting ready in the room. So that's ECMO aware. Then we have ECMO standby, which is a surgeon and a primed circuit in the room for the procedure. And so for PE interventions, those usually fall under our ECMO standby classification, because those kids are so unpredictable that we want a surgeon and a primed circuit ready to go, knowing that you may end up wasting some blood product and or circuitry as a result of an unused circuit, but accepting that is part of the nature of taking care of these patients, right? Because we're all under financial stress, right? You've got to be cognizant of the time and resources that you're spending, and you're wasting blood product, right? But we as an institution have agreed that for certain subsets of patients, we're going to do that and we're going to own it. And it's part of doing good patient care. And so that's how we've delineated kind of our ECMO processes. For like a good example where we use this quite often are newly diagnosed mediastinal masses, right? Like the bane of an intensivist existence. That's another always at 2 a.m. kid with a mediastinal mass shows up. A little bit of orthopnea. You're trying to figure out, is their head a little bit swollen or is it not swollen? And mom says their eyes are swollen, but you're like, the kid looks kind of okay to me. Where our general surgeons, like we've got an agreed upon algorithm now for mediastinal masses with ECMO built into that huddle and, having a circuit available, because just like with PEs, we were constantly reinventing a wheel that was too frustrating. And so I am not saying our protocol is by any means the best to use, but we did publish it because we know other institutions are trying to figure this out. We relied on the institutions you listed to help us build our program and what our response looked like. And that's sort of how we've gotten to where we are today, including with ECMO standby. So I think we all reach out to each other. And that's one of the things I love about the PEDS world, is that there's not a lot of malignant competition between institutions. We're all very happy to share the good, bad, and ugly of what we've learned. And please, for anybody who listens to this and is trying to figure out how to build a team, we're happy to share our experience. Dalia Bashir led the actual construction of the PE response team here. So she would be kind of the person I would say reach out to. I'm happy to help, but I'll honestly in full disclosure, probably tell you to talk to Dahlia because she did a good amount of the heavy lifting in terms of actually building the team itself. It's a nice thing to have in case you need it. And you can sim it, which is the other nice part, because it's a low frequency occurrence. Once you've got that protocol, it's really nice to sim it every few months to make sure that the teams are aware. And like you said, especially if you're at a bigger institution where you might not be on call the 4 or 5 times a year that this happens, once that protocol is in place, it's easy to sim over and over to make sure people are aware.
No, I love it. This has been an excellent conversation. There's been so much tacit knowledge that you've mixed in with the core fundamentals of hemodynamic resuscitation of a child in shock. We've mentioned interventricular interactions, cardiopulmonary interactions, vasoactive titration strategies, and ECLS. Like, there's so much knowledge that we can use, next time at the bedside, and then especially on those high stakes exams, just tend to come up from time to time. I think maybe as we move towards the close of today's conversations, what pearls or pitfalls might you want to emphasize for us as we close?
So I think the most important thing is to remember that the RV is distinctly different in its form and function from the LV, and that one of these things is not like the other, right? And so it is very easy to think about resuscitating the LV, and that's what's built into the PALS, right? PALS is all about the LV. Right? The shock guidelines are all about the LV. Everything is geared towards an LV with acute hemodynamic collapse, but there's very unique circumstances where it's actually the RV that's the driver. And if you treat the RV like you do the LV, you'll actually worsen things. And so I think just being really mindful of what's the actual pathophysiology that you're dealing with. Don't get stuck in the PALS mindset. Because, I think one of the things, and I say this, in jest and being friends with plenty of ER docs, but one of the things that makes being an intensivist so cool is we've got the time and the mindset to really dive into the nuance of what we're doing, right? And being incredibly thoughtful about why you're choosing what you're choosing and when. And so I think these types of resuscitations are when the intensivists shine, because you get the chance to walk people through the differences between the RV and the LV. Like, remember that volume is not your friend in a failing RV and will actually, if you're not arresting, make you full on arrest. Interventricular interactions are not to be underestimated. And it's so important to remember that more is not more better when it comes to epi, right? Like, you have to be thoughtful about what your doses are going to do to these patients, and is there a better drug to choose? Same with sedation, right? Like, there's times when a slow induction is fine, right? For the bronchiolytic, it's fine. They're going to be fine, right? But for the kids with a failing RV, you will kill them with a slow induction when you're getting ready to intubate. You have got to be thoughtful and quick and definitive in your action. And so I think, to me, as somebody whose world is slanted towards the RV, like, that's where I see kind of the most mistakes happen, is people just assume everything you're doing is geared toward the LV and it's going to be fine. Volume and epi and volume, but it's not going to be fine with certain subsets of patients. And so just be thoughtful, right? This is where the good intensivist shows. And so just remember the RV is different and treat it as such.
Oh, well, such valuable pearls. Dr. Ryan Coleman, thank you so much for joining us today.
And thank you guys for the opportunity. This was great. And I think it's so cool that you're doing this and the way you have it slanted towards, walking through why we do what we do, not just rote algorithm. Kudos to you, because I think it really makes, at least for somebody like me that really stinks at memorization, this sticks in my head so much more than just frank algorithms and things. So job well done. I wish this existed when I was in training.